Welcome everyone, thanks for joining us again for the BNProfessional series, and this month we have the privilege of Associate Professor Michael Talbot joining us to talk about the, I guess not so much when surgery fails, but when it doesn't go to plan or perhaps the results for the patient are not necessarily what they were looking for. So welcome Michael, and thanks for your time.
Great to be here.
It's lovely to have you here. I'm going to pretty much hand over to you. Just a few housekeeping things first I forgot to mention. Please, if you could keep your microphones muted. And during the presentation or the discussion, you're welcome to pop your questions or comments in the chat and we'll attend to those. And then at the end of the session, there's an open forum where you can ask Michael some questions directly as well. That's enough from me.
Failed bariatric surgery, it's a relatively emotive description, and certainly no sensible clinician would use the term apart from somebody who doesn't understand obesity and bariatric surgery, but it's something that patients will say quite frequently. So it's a reasonable thing to say, I think. Just a bit about myself. I've been doing bariatric surgery since 2003, starting with bands and bypasses and moving to laparoscopic sleeve and laparoscopic bypass in 2004. Do about 200 cases a year and a fair number of revisions. Bit of a plug, ANSMOS is running a dietetic roadshow at the moment. I've just had a corker of a meeting up in Brisbane a couple of weeks ago. There's a meeting in Sydney happening on the 28th of May and Melbourne on the 30th of June. You're registered for these via the ANSMOS website, and you can turn up live. It's going to be a live thing, and it's going to be lunch. We're going to sit in a room with real people, or you can log in virtually. Also, would be interested, or ANSMOS would be interested in considering events for WA and South Australia as well, and maybe Tasmania. But we need local people who can lend a hand with content. So it's actually availability of local people putting their hands up, which determines our ability to do these things. And also the ANSMOS meeting, it's going to be live or virtual, probably live by October, 27th to 29th of October up in Cairns. And we've got a very cheap rate. It will be the cheapest accommodation and flights up to Cairns that you'll ever have, because there's no overseas travellers. So when we're dealing with people who have perhaps got weight regain, we've got to be careful to learn something from history. It's very easy to not learn from history. When we see that the patients, this is what the consultation's going to look like. The person's going to be unhappy. They may not be entirely articulate. And often patients descend quite rapidly into binary thought processes. They either view things as being great or terrible with nothing in between. And their reason for presentation is because of a crisis. Usually the problem that they've got has been there for a while, however, they've just acknowledged it. And they feel the time for action is now because it's an emergency and they don't have time to waste. And they'll say, the surgery has failed, or I have failed, or something. And it's very hard as a clinician not to sit there thinking, why didn't you come back with a 5 kilogram weight regain? Why didn't you wait for a 20 kilogram weight regain? What's going on? And it's usually people ignoring problems for a time and then presenting when they've got a real crisis. It's worthwhile reorienting patients to what a normal BMI is these days. The distribution curve for BMI has changed over the last 2 decades, so that people who are in the overweight and obese group are actually more common than people in the sub BMI 25 group. And there's a lot of patients who present complaining or upset about weight regain who've actually got a perfectly good result. They're just in the overweight group. They want to be in the normal weight group. That's not a health decision. That's nothing to do with their health. And reflecting on the outcomes of the surgery that they've undertaken is often worthwhile. So the average weight loss from a sleeve gastrectomy in Australia is about 30%, 28 to 32, something along those lines. And it's therefore very rare for a patient to maintain a BMI below 25. So if somebody has a BMI of 40 and they lose 30% of their total body weight, they're going to lose 12 BMI points. They're going to end up at a BMI of 28. That's a normal expected response. So people pressuring themselves and to get to a BMI of 23 or to get to the weight that they were before they were married or 30 years ago is not relevant. The past is the past. We can't go back. For all of these patients, we've got to spend time knowing the backstory. All of our patients have got many years of weight problems and a cycle and a journey that's been difficult and unpleasant for them. They've got a genetic predisposition towards weight gain, and they've got learned behaviours which have allowed their genetic potential to be expressed. They will all have some health positive behaviours and some health negative behaviours, and a lot of the health negative behaviours are undeclared, and a lot of the work we've got to do is to unpick them and to get the patients to declare some of their negative behaviours, because you can't find a solution for them until you've had a conversation about them. And we've got to remember for any patients with weight gain or a weight problem that permanent weight loss of greater than 10% for an individual under their own esteem is almost unheard of. We were talking about this yesterday, Jacqui. What myths are the patients following? And we'll all hear a lot. And these are the ones that I get to hear, but I'm sure the audience has heard a lot as well. So patients have come in saying that their sleeve is stretched, when in reality, people who've maintained weight loss and people who have regained weight after a sleeve, well, both lots have had their sleeve stretch. The sleeve doesn't stretch up to normal volume. It's still very small. So stretching the stomach doesn't make people gain weight. They feel they would need a sleeve reset, and there's a few myths about that. A lot of patients come in demanding that what they need is a sleeve conversion to a bypass or something else. But that's not necessarily appropriate. Or they'll say that everybody they know this operation has failed, and so when their operations run into trouble, they've done nothing to defend it because they know it's going to fail. I try not to get too dragged into these sorts of conversations because they can go nowhere. But we can understand why patients feel this way, and what it's worthwhile looking for the audience. If you go to oswin.org.au, the WIN network is a support group or network set up by people who've got the lived experience with obesity, and they've put out their initial release document, and it's very sobering reading. And when you read this document, you reflect upon the obvious, and that's patients have all received a lifetime of poor information about weight management, and they're blamed when the therapy offered to them doesn't work, even when it was known at the start that the therapy wasn't going to work. Failure of appropriate advice for these patients is highly prevalent. So they turn up to consultations ready to be dismissed and ready to be offered advice that's not going to be therapeutic. And often they've been either offered no therapy or a placebo therapy, just diet and exercise, or very siloed therapy. So if you do this one thing, it will work fine, but you've got to do it perfectly. Whereas really patients need complex integrated care, not siloed care or simple care. So you have to talk about learning for the patients and learning for us. And we have to acknowledge the fact that the way we learn is through informational social influence or social learning. Most of us actually don't know that many facts. What we assume to be facts are in fact labels attached to previously processed data. And what we learn is a combination of editorialized data presented by experts or peers, and our responses are often behavioral rather than cognitive. So we do things in certain situations so it's situational based, but we often don't do things based on differing data inputs. And that's us. For a living, we do this sort of stuff, and we make complex, common cognitive errors about the things we view as objective data that are not objective data. And you can see this because what we say to the patients today is quite different to what we tell the patients in 2 or 3 years' time, even when the underlying facts haven't changed. It's even harder for patients. So they have the same learning style. So their information is gained socially. And these days, a lot of the information they get is learned from Facebook and blog sites. And it's easy for the patient to be influenced or seduced by the influencers who always have this hero transformative narrative as the hook into their website and their story. So patients learn from Facebook, but their behavior is actually influenced by their peer group. So when they come in for treatment, and they come in for our knowledge, we have an opportunity to counter some of their information influences. And the whole point of a lot of our consultations is to allow patients to change their behavior. So it's their behavior is influenced by their choices. So it's values-based behavior rather than previously learned habits, and also help them understand the effect that the environment has on their so-called choices. So if you structure your environment correctly, you'll make it easy to make the correct choice. If you structure your environment incorrectly, you'll make it hard to make the correct choice. There are a couple of post-surgery facts, and so I believe that these are facts, and I'd be happy to be challenged on them. Weight maintenance requires monitoring. It's a chronic condition. We monitor all chronic conditions, and while hopping on the scales is a relatively blunt tool, the act of monitoring your weight is an important thing for anybody with a long-term weight problem. Now, I'd suggest to patients that they have a weekly weigh-in and a health assessment. It's not just their weight, it's how am I living, how am I eating. When it comes to weight management, it's a lot easier to gain health than lose weight. And if we focus on weight as the determinant of our success, then we can fail to recognize the health gains with improving diet and exercise. I'm an anti-snacker. Snacks lead to weight gain, especially in patients who've had bariatric surgery. And patients often don't understand that their latte is a snack and a glass of wine is a snack. All of these non-food calories that patients have lead to what problems for them. But we can't be binary here. Patients need to have fun with food, as we all have fun with food. So getting patients to manage what they do with fun food is got to be part of the conversation. Exercise is integral to health and weight maintenance. Exercise isn't very good for weight loss, but it's brilliant for weight maintenance and maintenance of mood. And I think everybody needs a meal plan, not so much a plan of what will I eat, but when will I eat? If somebody determines, if everybody spent as much time planning when they were going to have their meals as they do planning their shoes and belt combination, a lot of problems would go. If you select when you're going to eat, then by default, you will not eat when you have chosen not to eat. And making the choice about when you're wanting to have your meals is really important, especially for our patients who've learned the diet binge cycle. They view eating as bad behavior and they try to avoid thinking about their meals, but they have to think about their meals. Otherwise, they're going to end up eating the wrong thing. So it's a bit of philosophical stuff. I'm now going to get to the technical stuff because I'm a technician, that's what we do. I don't think we get to select patients, they turn up, but we do get to select what we do with them. And the assessment process always involves the conversation about, were they happy with their initial procedure? I mean, you're always going to ask about what they were like before their procedure, but they want this procedure rescued. And I guess what I'm always interested in is, did they get the weight loss that they were wanting? And did they get disruptive side effects? And a lot of patients are prepared to put up with disruptive side effects, which increase their risk of weight gain. So it's very important to be specific and explicit about questions about food tolerances and dysphagia, regurgitation and reflux. Because if people can't eat proper food, they'll tend to eat rubbish. I'm always interested in if the patient, when the patient became unhappy, were they unhappy early, or did they have a period of happiness and then started to get weight regain or their side effects? And again, we've talked a bit about unrealistic expectations, which will promote unhappiness. And often it's a backhand comment from another health professional that has set them off on a tangent. They'll see an orthopedic surgeon who says, well, your BMI is 28, you need to be BMI 23 or some rubbish like that. So early on, defining what normal goals are like and what weight stability looks like can be very important, because a lot of patients, when they realize that they're just plumb normal, the urgency and the panic determines. So the energy and the panic dissipate somewhat. We have to slow down, and the patients are often pushing for a solution. But I like to mix a bit of evaluation with a bit of testing, with a bit of treatment, to try to create a hook to get patients back for more assessment. So I like to look at subjective assessments and objective assessments, on the understanding that no single investigation will give us the detail that we need, and no single conversation will be good enough. And that one visit's never enough to allow you to determine what's driving the patient's problems, unless they tell you the truth, which is unlikely. Usually they're hiding something about some aspect of their behaviour that they're not terribly proud of. What we're trying to do from a surgical point of view, and that's part of the team's role, is to think about whether this patient has disordered anatomy, because there certainly are patients who have a procedure that's no longer doing the job that it should, and it's the disordered anatomy that's driving some of their behaviours and weight regain. It's also whether the patients have got disordered physiology, and we have to acknowledge the underlying disorder of obesity homeostasis, which will tend to promote relatively easy weight regain in these patients. There's also some other disordered physiologies related to the anatomy of the surgery, including reflux, dysphagia, lack of satiety or satiation. And certainly there's a big relationship between reflux and lack of satiation. If you have patients with reflux, they'll often have a meal, feel they can't eat much more, 45 minutes later, they're ravenous. Those patients all have reflux, pretty much. Apart from the ones who have disordered eating behavior, such as addiction, if they're eating high sugar, appetite promoting foods and drinks, grazing, binge eating disorder, loss of cognitive restraint, maladaptive food choices, all of these things we've got to have conversations about. And it's hard to tease them out. And it's clear that unless we understand the mechanisms that are driving the poor weight loss, weight regain, or their symptoms, we can't apply a therapy to recruit new mechanisms of action. And there's a couple of things that we can do. We can offer patients surgically or band adjustments, increased restriction. We can look at things that offer appetite suppression that or might change their hedonic drive. We can look at malabsorption, which is a dangerous thing, metabolic effects. We can give reflux control. What I've found, and you in the audience have probably found this a lot as well, is that in many cases, especially with the sleeve and the bypass, patients have just learned to eat in the absence of hunger, that the cues they have for eating are related to environmental cues rather than hunger cues. And it's because the hedonic drives return. So sleeves and bypasses will knock off the hedonic drive for eating for about 9 to 18 months. Then it returns 2 to 3 years after surgery, and it's 2 to 3 years after surgery when patients start having problems. Subjective evaluation, I much prefer it if patients have the opportunity to see more than one team member, and preferably not the surgeon first. because if they see the surgeon first, they will try to hoodwink them into an operation, and they'll start to take control of the narrative and drive it towards interventions. Dietary assessments will all be aware that patients deny or block out addictive eating patterns. I used to think that patients were lying to me, and I used to get quite upset about it because it was clear that the patient wasn't telling me the truth. But then I realized actually they're not lying to me, they're lying to themselves, that they've created this pattern of behavior that they don't confront mentally. And so of course they can't tell me about it because they don't acknowledge it with themselves. But there are a few tricks that work quite well. One is to get one of their support people in the room, a sister or a brother, a workmate or a spouse, apart from if the spouse is part of the disordered thinking, which will happen on occasions. Food diaries are really, really handy in this respect. Not the phone-based ones, though the phone-based ones are good. If you give them a written food diary and get them to fill in what they have for 48 hours, they will tell things to that diary that they will not tell you ever. And it's the same thing with a lot of the inventory scores. If you ask patients about binge eating behaviors, they'll say no. If you give them a binge eating inventory, most will be honest with the inventory and not so much you. So if what the patient is saying doesn't add up, there's all of these escalated assessments you can do. On top of the food diary, you can do 7 or 14-day continuous glucose monitoring and an exercise tracker to try to relate their glucose spikes to their reported eating. So you can't lie to your blood glucose. Body composition scans look at how much muscle they've got because it's a target they can work with, and knowing what their metabolic rate is as well can be really important for these patients. Psychologists are really useful, but it's hard to know where to put them in this assessment process because patients can be incredibly resistant to them. In fact, in the past, I'm not very proud of pointing this out, but one of my previous strategies, if I wanted to get rid of a patient, was to say, we've had a breakthrough today. I think we should get you to see the psychologist. And I'd know that the patient would never return because they don't want to have those conversations. But I think if you suspect that the patient's disruptive or got a borderline personality disorder, you must send them to a psychologist. So if the patient comes in and says a lot of things about their previous clinicians, that's a red flag, and you should start thinking about getting them off to a psychologist in order to determine whether they are going to be difficult for your team to manage. And I can manage them, but I work with my team. I don't want to inflict upon my team somebody who's going to psychologically injure them. So band, sleeve and bypass, we've sort of been through this a bit. Subjective appointment assessment with the first appointment. So usually what happens to me, if I'm lucky, is the patients will see one of our physicians first, and then often consider a second appointment with some extra subjective stuff, such as seeing the dietitian or the psychologist, or trying some simple things and coming back with more of a history, and getting the patient to do some homework to invest in their weight management between appointments. Then usually after I've seen them, I'll bring them in for a post-appointment anatomic assessment with either a barium swallow for a band or an endoscopy combined with a 3D CT scan or manometry for sleeves and bypasses. A couple of reasons. I want to see if there's abnormal anatomy driving some of the abnormal physiology. Also, it's really good if you've got a sleeve or a bypass and you can show them a picture of their stomach, and you show them their stomach is tiny and it's not stretched. It's still only 40 cc's in size. It's a really handy tool because then you can tell them what happens when they eat and where the food is going. So the anatomy assessment is a really positive thing for the patients. Not often gives you clues about what things you could do if you're going to operate on them. Second appointment comes, and that's decision time. And the two decision points are really either interim therapies or definitive therapies. And so the interim therapies are often definitive therapies. So there's a whole lot of medical adjuvant therapies we can often offer people. And you can start this during the assessment process for those patients with weight regain to get them to lose weight. So a lot of the patients we're seeing, they've gained 8%, 10%, 15% from their best weight, but they really only need to lose 5 to 8% of that. And they'll be happy with that often. So if you start people on effective medical therapy, it engages their compliance, so they're more likely to return for further follow-up. And it gives you time to assess them more to see if there's any problems that you don't know about. And it allows you to avoid revision surgery in a lot of the patients. And a lot of these patients, when you give them the therapy that suppresses appetite and changes their food preferences, they can then reflect back on how they've been eating before you started the therapy and what changes they can make in order to prevent that from happening again. There's other interim medical therapies such as VLEDs, exercise, especially for younger patients, or other short-term diets. If the patient's done very well in the past with, a Mediterranean diet or an Atkins diet, and there's really no harm in putting them back on it for a month to 6 weeks, just to give them a bit of a kickstart while you're planning further therapy. And the early aim is really to achieve weight stability and maintain engagement while you continue their assessment. And we've got to be aware of offering patients effective therapy that gives them a chance of getting what they want. Just a couple of slides on some weight management studies. So here's a small study of 60,000 patients, and you can see here for the treating clinicians treating these patients for a year, by about the end of the year of therapy, they've got 10 to 12% total body weight loss, which they'd be very happy with. But when you turn it around and look at the retention, what you'll see is at the end of the year, 5 to 8% of patients are still coming back for further follow-ups. So the clinician is seeing the opposite of what's actually happening. They're offering therapy to patients that they cannot tolerate, and rather than switching them to something else, they keep them on that monotherapy and they lose the patient, which isn't what we want. We want to keep the patient and offer them successful therapy. Contrast that study with the new wonder drug, which is the GLP agonist, and this one, semaglutide. Study over 16 months, I think. Over that 16-month period, 85% of patients lost more than 5% of their total body weight, and half the patients achieved a 15% total body weight loss in a year and a half, and only 5% of patients discontinued. So if you offer patients effective therapy, they will engage. Maybe not for longer than a year or two, but you can get them to engage. Problem with this medication is this protocol would be about $5,000 per year. So, but in 10 years' time or 5 years' time, we might find this is going to be a lot more affordable. In a patient with a normal stomach, and this is another arm of the similar trial, if you have a patient who's lost weight or lost weight with a GLP-1 agonist and got to 10% total body weight loss, and you continue the therapy, the patients go on to lose more weight, albeit slowly. But if you stop the therapy fails and the patients regain their weight. That's not the same for a patient who's had a sleeve or a bypass. Now, the data we have on this aren't great, but we've given liraglutide after bariatric surgery to well over 150 patients now. This particular slide's 3 years old. Most patients lose over 5% total body weight, which is similar to the semaglutide trials. And 1 in 5 patients will lose more than 10% total body weight loss. And what happens to these patients is we haven't had to operate on 200 of them. It's not like we've given the liraglutide and then they've stopped the therapy and regained their weight and come back. The large majority of these patients haven't required or haven't chosen further surgical therapies because they've been happy. Now, there's some that have, and we haven't lost much because all we've lost is a bit of time, and it's allowed us to choose what surgical therapy we're going to offer them. But it's been a very effective way of helping patients avoid surgery because they've got a small stomach. They're not hungry. They've got habits that they need to change. And if you can give them 5, 8, 10% total body weight loss, they're happy because they're then back on their weight maintenance pathway, which is quite different from a weight loss pathway. Will surgery be undertaken in some patients? Yes. It'll sometimes be an appropriate therapy, but we need appropriate indication. So reflux and side effects are a good indication for revision therapy because you're trying to improve the patient's quality of life. Weight regain is a little bit trickier because the issues with the surgery are greater. And we do want an appropriately engaged patient, but it's hard to know how long they're going to stay engaged for. If somebody didn't stay engaged for their first operation, will they stay engaged for their second? They'll always say they will, but they may not. But if the patient's been returning to you for 6 months for assessment and they've had appointments with all your team members, at least you know that you've done your best. And if the patient stops engaging after surgery, at least they've had a chance and they've proven that they can engage. So what are the data like? So the data for reoperation of band to sleeve or bypass are pretty acceptable. Band to sleeve can be a little bit disappointing in heavier patients and probably isn't a great procedure for people who've weighed more than about 120 kilograms. The median weight loss is about 20%. Band to bypass is pretty similar to a standard bypass, about 30% total body weight loss. But the number of non-responders, so patients who lose less than 20% total body weight loss, is at least 1 in 5. Whereas seeing somebody lose less than 20% total body weight loss after a gastric bypass is very rare. It's uncommon, but it's quite common in patients who've had previous bands. Data for sleeve to bypass or bypass to other procedures are pretty poor. You can assume that a 15% total body weight loss is going to be the best you're going to do. 10 to 15% is probably about it in most of the studies. And we've got to assume that the risks are 4 to 5 times higher than primary surgery. And since you can get 10% total body weight loss with semaglutide, you've got to select patients pretty well before offering them a major operation with that type of weight loss. Talk about some of the assessments that we do. Gastroscopy is expensive. It's not objective, but it's usually performed, so we just accept it. Functional swallows, so barium swallows, are cheap, but of pretty variable quality. They're good in the chest, evaluating the esophagus, but they're pretty bad at evaluating gastric pouches. We prefer functional CTs. They're very cheap. They're very good above and below the diaphragm, and you can get them done quickly. It's very hard to find X-ray places who'll do barium swallows these days, and they give you objective data. Manometry is less commonly done elsewhere. We do a lot of it, mainly because it's not that well understood by clinicians. So this is what a normal sleeve might look like. We can see the esophagus. If the esophagus is dilated, it means that it's acting as a reservoir. We see where the diaphragm notch is in relationship to the top of the stomach, so we know if there's a hiatus hernia. If the angularis is narrow, that can cause reflux because it's cystinosis. And at the bottom of the stomach, we can see the normal pyloric notch. When you do these sorts of scans, you'll see all sorts of things, and some of them mean something and some of them might not. So you can see the picture up there at the top left, patient with a very tight sleeve stenosis causing reflux. The one more in the middle with a torsion, that the sleeve is corkscrewed around itself because of the winding staple line. That'll also lead to obstruction with eating. Patients with symmetrical, asymmetrical sleeves, patients with hiatus hernias, patients with dilated or large stomachs. So there's a lot of variations of normal and abnormal, and it's hard to define what they can be sometimes, but we will know what the esophageal diameter is. And if it's wide, it'll lead to reflux. We can see a hiatus hernia, which predisposes to reflux. We can see what the stomach looks like above and below the angularis, whether this is stenosis, and we can get a feel for tube volume if the patients are worried about the stomach stretching. The other part of the physiologic assessment, and we don't have great tools for this, is looking at hunger. There are actually assessment tools you can do. There's a 3-factor eating score, which is a 17-point score that you can offer patients to do if you're wanting to find a little bit more about their appetite and hunger. But I've found the results relatively opaque. So I tend to just ask the patients a lot of questions, and it's clear that many confuse the ability to eat with the desire to eat. They want to feel full, whereas we all know that feeling full is not part of normal eating behavior. They confuse desire to eat with hunger. And you know, you reflect back on them that nobody eats chocolate chips, crisps, or whatever because they're hungry, and you don't have a glass of wine or a tall latte because you're thirsty. You're doing it because you like it, not because you're thirsty or hungry. And there's certainly operating on somebody who's lost an addiction is pointless and dangerous. And it does happen occasionally, thankfully, quite rarely, but it's very unpleasant if these patients slip through. And for these patients, often, if I'm concerned, that's when I pull out the food diary and an appointment with a family member if I'm worried about addiction that's undeclared. Reflux, regurgitation, and dysphagia, these are significant drivers of weight regain and disordered eating, and they can be fixed often without complex surgery. These things promote consumption of high energy, low nutrition foods and drive a preponderance of abnormal eating behaviors that we want to avoid. I think bad dysphagia symptoms are probably a reasonable indication to consider surgical therapy. What sort of things can we do? These are not particularly good words, but they're words that clinicians understand. Restriction, malabsorption, bit of both. Do you do things differently depending on the patient? Well, I do things differently because I like to make life complex for myself. And I'd like to talk a little bit about malabsorption, which was thankfully unfashionable for a while, but is coming back in fashion again. If you compare a standard gastric bypass versus a distal gastric bypass with a short BP limb and a short common channel, what you'll see is that the addition of malabsorption leads to increased complications but no improvement of weight loss. So adding malabsorption is not particularly helpful. But what we have seen is if you fiddle with the biliopancreatic limb, which is the part of the small bowel that carries digestive enzymes to mix in with your food, if you lengthen that, that can have an effect on improving weight loss. So usually an extra 5 to 10% total body weight loss without creating monstrous malabsorption. It's probably one of the reasons why people who do standard mini gastric bypasses claim better weight loss than standard short limb Roux-en-Y gastric bypasses. They've got a longer BP limb, which gives an extra 5 to 10%. However, people have stopped doing standard limb bypasses these days. Also, if you get a patient with the Roux-en-Y gastric bypass and you offer them a lengthening procedure, not leaving their common channel short, but just lengthening their BP limb and leaving them with a lot of absorptive length, you can get up to an extra 15% total body weight loss. And that's extra weight loss without creating severe nutritional problems. So at 250 to 300 centimeters, in this series, they had 1 in 5 patients requiring revision for malabsorption, but at 400 centimeters, they had no revisions, which sort of fits to a degree with what we see with the duodenal switch. So why does a longer BP limb lead to increased weight loss when the common channel available for absorption is still at least 3 to 4 meters long or longer? And especially given the short common channels, don't lead to weight loss and do lead to horrible malabsorption. Well, there's a couple of theories: the thermic effect of eating, increasing basal metabolic rate, maybe denaturing of pancreatic enzymes to increase that thermic effect of food. What happens to the enzymes in a biliopancreatic limb? If you put a probe into somebody's duodenum, 40 centimeters in the duodenum plus 40 centimeters past the jejunum and downstream, and you measure the activity of enzymes, what you'll see is that as the bile and enzymes move through the gut without food, they become progressively denatured. So the enzymes, in the absence of food, digest themselves. So by the time you're 80 centimeters away from the DJ flexure, you've turned your enzymes off completely. And this reflects what happens to us normally. If you and I eat a meal, the first meter of your small bowel does all the work. 90% of your calories and protein is absorbed within the first meter of your small bowel. The rest of your small bowel is predominantly just absorbing minerals, which are absorbed inefficiently, and vitamin B12, all the actions at the front end. So if you don't have food going through that part of the small bowel, you get denatured enzymes. So by about 80 centimeters down the track, they're down to about a third of their overall function. So all of the enzymes deactivate themselves, which probably means that the work of absorption is now spread over the entire small bowel length. Rather than the first 80 centimeters absorbing everything, the entire small bowel now has to work like a slave and go for a run every time you eat. That gives you products of undigested food towards the end of your small bowel, which increases GLP-1 creation, as well as bumping up your metabolic rate. Beyond a certain point, you'll get fat malabsorption, which will be bad for patients and bad for your practice. You'll certainly see carbohydrate and fat intolerance in patients with longer bypasses. And these patients have to have a diet that's high in protein, otherwise they don't do well. And it would be a mistake to offer a loop duodenal switch or a long limb mini gastric bypass to somebody who was vegetarian or somebody who already has bad FODMAP symptoms. Because what you'll create with these patients is FODMAP symptoms. They'll get bloating and discomfort from complex carbohydrates. Paradoxically, we want our patients to eat complex carbohydrates. It's difficult. You can give them these enzymes, which are very expensive, but handy if the patients want to be able to go out socially without farting. So the loop duodenal switch, or the SADI, or whatever they call it, it's a marketing tool, it's a duodenal switch. These will all create markers of fat malabsorption and bile salt loss if you fiddle with the small bowel enough. Markers of fat malabsorption, which don't cause problems, are seen very rarely in normal patients. In 5% of sleeve patients, 10% of Roux bypasses, and 80% of patients with standard BPDs. We don't know whether the OAGB or the SADI also has fat malabsorption. But for these patients, at some point, AEDK vitamin supplementation and monitoring is going to be required above and beyond our standard multivitamins. And this extra monitoring and supplementation is one of the reasons why I'm a little bit anxious about these procedures. I do think the loop duodenal switch is probably going to be applicable for patients with sleeve revisions, for weight regain, mainly because sleeve to bypass procedures are a bit ordinary sometimes. It's a simple procedure, but non-standardized with the gastric volume, and the common channel does have to be over 3 meters. If If you do this, what happens? You get an extra 10% total body weight loss, basically, if you convert a sleeve to a loop duodenal switch. This has been brought out in literature. Patients with 250 centimetre common channel did have quite scary vitamin and mineral deficiencies, but with a 330 centimetre channel, it seems to be less of a problem. But selenium, zinc, copper deficiencies all occur, and you just never see those with standard gastric bypasses. So doing these procedures creates an opportunity for complications that we're not used to managing. So I'm happy to do a duodenal switch in a patient from a sleeve. I think band to sleeve often predicts a failure from sleeve to bypass. So if a patient's had a band and then had a sleeve and regained their weight, a lot of my patients that have then gone to do a bypass haven't done well, and I prefer to do a loop duodenal switch for them. Patients who are carb eaters and snackers rather than big meal eaters, because the duodenal switch will make them intolerant to the carbohydrates. But poorly compliant patients will create a medical legal nightmare. So if they haven't been keen on follow-up, they don't like coming in for appointments, I'd just rather run away from them, because if they don't take their multivitamins, I'm going to be in trouble. Going back to the 3D CT scan, so different things for different people. So the person on the right-hand side with the sleeve stenosis, they have to have a bypass because nothing else is going to work. They've got an obstructive stomach and a loop duodenal switch won't work. The person on the other side could have virtually anything, including perhaps a re-sleeve, gastric bypass, or a loop duodenal switch with trimming of their stomach. If they had a weight problem, I'd probably offer them a bypass because it's easy and safe, because you're only making a very small extra staple line rather than restapling the whole thing. This person who's a patient of mine who's 10 years after a sleeve with the sleeve volume of 277 cc's, grazes a lot, can't eat massive meals. I'm not going to do a bypass on her because making her small stomach smaller isn't going to do anything. I'm going to want something that changes the mechanism to a more metabolic one. And so this is the sort of patient I'd do a loop duodenal switch in. Getting to the end. So bariatric reoperations and management of weight regain are part of our day-to-day work. Revisions for weight regain are greater risk of being disappointing and higher risk, especially now that we've moved from doing band to bypasses to sleeve to bypasses. They're entirely different animals. Revisions for complications will create the risk of new complications, so try not to do too much. And weight regain is not an emergency. Thank you.
Struggling to unmute. Thank you so much. And seeing your view on all of this and your experience with it is totally fascinating, because we hear in the groups people are just popping into the surgeon to get another operation, and it's certainly not as simple as that. So
madness.
Yeah, we hear it a lot. You know, this surgery's failed, so I'll just go get another one. And to me, it's quite surprising how surgery becomes something that you do or something that you'd willingly do more of, not necessarily, you know, look at all these other interventions in the meantime.
Especially when you understand what the data are about the results. The results, like, you know, band to sleeve, band to bypass, they're okay. Sleeve to anything else, bypass to anything else, so-so. And there are other alternatives which are effective and safer.
I've had a question, Michael, and I don't know if it's on the lips of all of our other attendees. With the medical interventions that you use between surgeries, so the different drugs that you use for weight loss, alongside that, how would that look? Do you then direct them to behaviour change at the same time? And what would that look like if that's the case?
A lot of the medications require dose adjustment. And so that gives you the opportunity to cycle people back in for, you know, appointments. So you give them a therapy, patient feels that their appetite's gone, they're losing some weight, they'll come back for another appointment in a month. Then you look at how they're going, and then ask them what the barriers are. The medication's not the be-all, end-all. It gives them a bit of a tailwind. You have the opportunity then to say, well, where are you doing well? Where are you doing not so well? What do we need to apply pressure on? And sometimes it's psychologists, sometimes it's relationship counseling, sometimes it's addiction therapy, sometimes it's just restructuring their diet, sometimes it's just repeating the same message. So the nice thing about medications is that, that they can't just get it and disappear. They've got to come back for dose adjustment. And because the therapy gives them appetite suppression and makes weight loss easy to achieve, they find compliance a lot easier. They'll actually seek reappointments rather than avoiding you.
And it is a method of remotivating, isn't it?
Yeah.
I think if someone's keen on seeing their surgeon again with the opportunity for future surgery, and you say, well, in between, we need to follow all of these steps to eliminate, or explore whether there is a need for further intervention, that when they start to see results again, surely that would help, I would think, to keep them on track with their eating plan and that sort of thing.
And a lot of them will, they'll self-direct away from surgery. They're keen on it, and then you do something else, it's just as effective. They get a goal, they get back to goal, the pressure comes off, and they just go back to living their lives, paying a bit more attention.
Yeah, a bit of a reset of sorts as well from their, habits that they might have revisited.
Had issues with,
Yeah, particularly it's interesting when you say that 18 months to 2 years was where you see people coming back saying this didn't work out. It's generally that when hunger returns. I had someone during the week asking me about that, as far as the metabolic component of, say, a sleeve surgery, where hunger subsides because of the hormonal changes and ghrelins intervention and I guess keeping insulin out of the picture as much as we can. Is there ever a time where those metabolic changes don't take place after the surgery for a patient, and that is genuinely they haven't got the metabolic changes they were looking for that would help with the weight loss? Is that a possibility?
You'll see it occasionally in older people with lower body muscle, with less muscle in their bodies. So people in their 60s and 70s, sometimes you'll see that they'll not respond as much. But unfortunately, the majority of people, especially if it's a primary sleeve or bypass, who don't respond well, it's usually sugars or alcohol.
Right. Not the easiest things to uncover in a simple conversation.
No.
Unfortunately. And so I guess that's, where we go with the support we offer in the education platform with the groups and that sort of thing, is really reminding of that, protein first, and actually walking them through the education process of what is a carbohydrate and what does alcohol do to you, and really kind of just keeping all of that top of mind. But the resources you showed earlier on, the flyer you had displayed with was it
Oswin, yeah.
I hadn't seen that before. So these forums are such a great opportunity to, share different resources that we can all draw on in practice as well, which is good. I'm looking at our chat box. I don't have any other questions from our very quiet audience.
Well, it's a Monday, it's a school holiday, honestly.
I know, we're all coming down off our Easter eggs too, I think. So we will post the video and we send it out to everybody who registered, and we're totally grateful for your precious time And yeah, your sharing of knowledge and yeah, helping us to understand what it might look like for a patient as well is really worthwhile. Thank you.
No trouble. Hope I didn't talk too much.
No, we're all here to learn something. So it's yeah, it's great, and we look forward to seeing you at the roadshow. How do if any of the participants are not yet registered, is there a website they can visit?
Yeah, the ANZMOS website. It's just at the top. It says Integrated Health Roadshow, and you click on the link, and it gives you the program. So the programs for each of the sites is actually different, which is we're making life hard for ourselves. But you can actually go to each of the different roadshows and get completely different content.
And see the team from BN Multi at each one. But we attended the Brisbane one, which was very easy for us. And it was such a great opportunity to, again, expand our understanding of what's coming up as, you know, new issues with bariatric surgery and that sort of thing. So I certainly recommend it. And just to see some people again in the flesh was
it's nice.
So all going well, we'll all be down there. So, and the Melbourne one is in July, I believe. Is that right?
Yeah, July. Yeah. So July the 30th and May the 28th, yes.
Yeah.
And lock away your diaries for October, end of October, up in tropical far north Queensland.
Yeah, and I think now we've got this pathway to New Zealand. We've got all these exciting conferences happening this year.
Yeah, I think that's a little bit more complex because of the risks of lockdowns and things. So state lockdowns will be a bit easier to manage. But
I think so.
Yes,
and when you're Jacinda and Anna, you're in trouble. We didn't go anywhere. Well, I'll sign off and I'll thank you all for your time, and I'll see you on the roadshow.
Absolutely. See you then.
Take care.
Bye.
Spectacular. Are you there, Kate? Turn that off.